I'd like to begin this morning by acknowledging the traditional owners of the land wherever our attendees in Australia are coming from today. I'm currently on Wurundjeri Woiwurrung land in Melbourne's east. I would like to pay my respect to elders past, present and future. I affirm that sovereignty was never ceded and that colonialism and racism continue to impact on the lives of Aboriginal and Torres Strait Islander women. I recognise the strength, resilience and leadership of Aboriginal and Torres Strait Islander women and express my hope for reconciliation. I would also like to acknowledge any Aboriginal or Torres Strait Islander people joining us today. My name is Vanessa Cherniowski. I use she, her pronouns, and I am the Health Promotion Coordinator working in the mental health priority area at Women's Health East, and I will be your host for this morning's webinar. It's really great to see so many people here today, and especially those that came to the first webinar 2 weeks ago. Hopefully today's content will build on your understanding of women's mental health promotion. Firstly, just to get some housekeeping out of the way, we ask that participants remain on mute for the webinar, but we do welcome conversation in the chat box. My colleague Ada will be monitoring the chat, so please feel free to post any questions you have for our guest presenters throughout the webinar into the chat box. And we'll have question time at the end of the session where we'll aim to answer as many questions as possible. Please feel free to also send Ada a question directly. If you'd prefer to remain anonymous, that's absolutely fine. The webinar will be recorded and will be made available after the session. So the aim of today's session is to build an understanding of gender transformative and culturally safe mental health promotion. We'll start with an overview of gender transformative mental health promotion to set the foundation. We are then really thrilled to have Monisha Vaid Sandhu from the Multicultural Centre for Women's Health presenting to us this morning on refugee and migrant women's mental health. We'll then be showcasing some local mental health promotion projects from the region, including mental health promotion projects from the Women's Health East bicultural team. We will then finish the morning with question time. At the end of the webinar, a quick anonymous evaluation survey will be available for you to do straight away by scanning a QR code, which will be on the screen. And we'll also put the survey link in the chat at the end of the session for you. The purpose of the survey is to assess the impact and usefulness of this morning's webinar to shape future events. So the information you provide also enables us to continue to hold free and informative events for our community. So we do have a very exciting and action-packed agenda today, and we're really glad that you could be here. As we will be talking about mental health today, there's some numbers on the screen you can call in a crisis if you or someone you know needs support. There are also local support services available, and Ada will be posting the details of these into the chat box. Additionally, we'll also be touching on family violence today. If you or someone you know needs family violence support, there are crisis numbers on the screen. If you live in Melbourne's east, the Orange Door Family Violence Service operates in both the inner and outer areas of the east. And again, we will put those additional contact and support information into the chat for you so that it's easily accessible. I just wanted to give a quick overview of Women's Health East before we dive into today's content. So Women's Health East is the regional women's health promotion organisation for the east of Melbourne. We're one of 12 women's health organisations across the state, and we drive action to build an equitable society. Guided by evidence and informed by women's lived experiences, we strengthen the capacity of partners and community to improve women's health and wellbeing. Our priority areas are to advance gender equality, prevent violence against women, and to improve women's sexual and reproductive health. A recent addition to our priority area is women's mental health. Our work in mental health promotion had previously been reported together with our GE work, and we're really pleased to be able to have a continued focus on this important area moving forward. For Women's Health East, we see our role is to work with our partners to build their understanding of women's mental health, the impact gender has on their experience of mental health, and implications for health promotion practice. At a broader level, the Royal Commission into Victoria's mental health system, along with the COVID-19 pandemic, have drawn attention to mental health and illness, both as a serious public health issue and one that is also deeply gendered. A key opportunity included the work commissioned by the women's health services sector to develop the theory of change for women's mental health promotion. And that's that diagram there on your screen. This document was developed by Dr. Helen Kelleher, Gender Equity Victoria, in consultation with 10 women's health services. The framework sets out the theory of change for gender transformative approach to mental health promotion, and these principles have been integrated into what we will be talking more about this morning. Also, in the context of the Royal Commission, Women's Health Victoria established the Women's Mental Health Alliance in 2019. The Alliance provides expert advice to policymakers and health services on mental health of women and girls, and also undertakes advocacy to ensure all women have access to evidence-based, gender-sensitive and trauma-informed mental health support. The Alliance works to ensure the voices of women with lived experience are centred in policy advocacy and service delivery. So today's webinar is part 2 in our 2-part series. And I know many people here today attended the last webinar, but I did want to give just a brief recap to jog our memories and also to provide just a little bit of context for those that weren't able to make it to webinar 1. So we looked at statistics around women and girls' mental health and learnt that Australian women experience significantly worse mental health than men across every age group, and that a greater number of younger Australians experience higher levels of psychological distress. We also learnt that mental health outcomes were exacerbated for women during the COVID-19 pandemic. By acting on the key social determinants of mental health, we learnt there would be significant decline in population level mental illness. The evidence indicates that mental health promotion programs that address social inclusion, freedom from discrimination and violence, and access to economic resources are most likely to be effective and reduce the prevalence of mental illness at a population level. We did learn that these determinants are also deeply gendered. We were fortunate enough to hear from Dr. Kate Johnston-Atta from Women's Health Victoria. Kate provided a detailed overview of why a gendered approach to women's mental health is really needed. A recording of the session 1 is available, and Ada will post a link to this in the chat box. So if you want to go and have a listen to that, if you weren't able to make the first one, it is available. A key discussion point among attendees at the first webinar was the mental health for women who experience structural inequality and other forms of discrimination, including racism, classism, ableism, ageism, and homophobia. And we know that this creates social exclusion, and it can also compound mental health impacts for women. I would at this point just like to acknowledge that we predominantly talk about women and girls throughout this presentation, as this is where we have most of the research and statistics. However, gender identity is fluid. We would like to acknowledge that people who don't fit in the binary concept of man or woman are more vulnerable to discrimination and experience poorer mental health outcomes. Aboriginal and Torres Strait Islander women, women with disabilities, refugee and migrant women, young women, lesbian, bisexual, transgender and queer women, and incarcerated women experience worse mental health outcomes due to the multiple forms of discrimination. Just to give an example, 73% of LGBTIQ plus Victorians have considered suicide, compared with only 13% of the general population. And 9.4% of young LGBTIQ Victorians have attempted suicide in the last 12 months. In relation to trans people, the latest studies show that lifetime diagnosis of depression was reported at 73%, and anxiety by 67%. And 63% reported previous self-harm, and 43% had attempted suicide. So I think, we can really see these statistics are extremely distressing, and they demonstrate the continued discrimination, stigma and exclusion experienced by the wider LGBTIQ+ community, and that real need for much more work within this area. A focus on the intersecting forms of discrimination that women face and the impact of this on their mental health will be highlighted today by our guest presenter, Monisha, who will look at migrant and refugee women's mental health. So today is a great opportunity for us to learn not only about gender transformative mental health promotion, but also the importance of culturally safe health promotion practice. That's enough from me. I would now like to introduce our first presenter, Dr. Belinda Crockett. Belinda is the Health Promotion Manager at Women's Health East. She's worked within alongside the women's health sector for many years and holds particular interest and expertise in empowerment and participatory approaches to evaluation. Belinda has a research and teaching background. She completed her PhD thesis on women, HIV and development in Papua New Guinea, and prior to that, her honours research on women living with hepatitis C in Melbourne. So thank you, Belle, and I'll hand over to you, and you just let me know when you want me to change the slide.
Thanks so much, Vanessa, and good morning, everyone. It's great to be here and to see so many of your smiling faces. Over the next 10 minutes, and thank you for the introduction, Vanessa, sorry. Over the next 10 minutes, I thought I would guide us through a brief overview of some of the key principles for taking a gender transformative approach to mental health promotion. I do emphasise the word brief, since it's simply not possible to go into any great depth in this time frame, but hopefully we're able to set the stage for the wonderful presentations to follow, including the case studies from the region, which I'm really looking forward to hearing about. And hopefully through those case studies, you'll be able to hear a little bit more in depth about this approach and to see some of the principles actually in action. I thought it would be useful to firstly look at what we mean by gender transformative health promotion, and to then discuss the principles and the evidence base around how we integrate this into our mental health promotion practice. Thanks, Vanessa. Next slide, please. Thanks, VC. So Women's Health Victoria's paper on gender transformative health promotion highlights how practice involves challenging, critically examining, and in transforming the gendered norms, practices and structures that create and maintain gender inequality, and how we strengthen actions that support gender equality. I really like this definition because it speaks to the complexities in our work, and it gives emphasis to transformation or transformative action to change systems and structures. Taking this approach enables us to not only become sensitive to gender inequity, but to actually challenge and seek to address the underlying causes of gender inequality. Through a gender transformative approach, we therefore take a focus on improving health equity inequities, as well as furthering gender equity. Thanks, Vanessa. On the screen, you'll see a framework developed by Peterson et al. And the framework builds on our understanding of gender as a determinant of health. The framework outlines a continuum of approaches that can be used when implementing health promotion interventions. We can see the continuum spans from approaches which are gender unequal at the exploit end, progressing through to gender transformative at the aspirational transform end. An example of a gender unequal or gender exploitative health promotion intervention to address smoking in women, for instance, would be encouraging women to quit smoking to preserve their looks, thereby actually further perpetuating inequality by playing into the social stereotypes of women being most valued for their appearance. So not only does this do absolutely nothing to challenge the status quo, but it may actually cause harm. A gender transformative approach to health promotion, on the other hand, reduces both gender bias and health inequities. Looking at the prevention of violence against women as an example of gender transformative health promotion, it might involve, for example, the promotion of flexible employment conditions to working fathers while challenging the idea that caring for children is a woman's job. This works to transform gender norms, roles, and power imbalances. It's important to note that while recognising gender as a fundamental determinant of health, gender transformative health promotion also encourages an examination of the links between gender and other determinants, such as race, income, education, occupation, and processes such as marginalisation, discrimination, homophobia, transphobia, racism, ableism, and sexism, therefore implementing an intersectional analysis. A gender transformative approach is also one that is culturally safe. And we're very fortunate to have Monisha here, who'll speak to you a bit later this morning from the perspective of migrant and refugee women's mental health. Thank you, Vanessa. So we've considered briefly what a gender transformative health promotion approach looks like, but what does this mean for our mental health promotion practice? How do we actually bring the two together? So on this slide, you'll see an amalgamation of some principles and key action goals, which I've taken from the literature. I'd like to give a shout out to a colleague of ours from another women's health service, Susan Timmins, who contributed to this list. I won't read all of these out in the interest of time, but as Vanessa pointed out, the slides will be made available, so you won't be missing anything. But essentially, a gender transformative approach to mental health promotion puts women, girls, and gender diverse people at the centre of our work, interrogates gender roles, expectations, stereotypes, and norms, requires partnerships and complexity-informed and participatory design, implementation, and very importantly, evaluation, and requires investment and innovation in research, data system, and capacity building. And we're all here today to actually build our understanding of a gender transformative approach to mental health promotion. And of course, what's missing here from this slide is the explicit recognition of the importance of an intersectional approach, as we have just talked about before. We should also ask ourselves, are additional principles and approaches required to meet the needs of groups of women, including Aboriginal and Torres Strait Islander women, refugee and migrant women, and women with disabilities, for example? Okay, thanks, Vanessa. Despite the need for gender transformative mental health promotion, investment, development, implementation, and evaluation in this field has been relatively limited. Whilst this can make evidence-based practice difficult to define, we can actually take our cues from a number of frameworks. And here on the slide, you'll see the Vic Health Melbourne Charter represented. And this is a rights-based framework for mental health. And it draws or builds quite heavily on our much-loved Vic Health framework for mental health promotion from 2005, which identifies the key social determinants of mental health being, of course, freedom from violence and discrimination and stigma, access to economic resources, and social inclusion. You'll also notice that there's been a significant body of research that offers solutions and guidance on the key elements required for a gendered approach to mental health promotion. This includes the growing evidence base and national frameworks for the prevention of violence against women, such as Change the Story. By integrating these frameworks, we are given advice on how to develop gender transformative mental health promotion actions. We'll now take a little look closer at some of the principles that have been mentioned so far. Thanks, Vanessa. In webinar 1, we unpacked how gender inequality can impact in a myriad of ways on women and girls' mental health. So challenging gender inequality is key to promoting women's mental health and wellbeing. It is vital that we continue to challenge gender norms and stereotypes and expectations that negatively affect women and girls' mental health. Additionally, we need to move away from binary notions of gender to a more gender-inclusive way of working. Thank you, Vanessa. At our first webinar, we looked firstly at the population level social determinants of mental health. We found that the evidence demonstrates how mental health programs which seek to address the underlying determinants of mental health are most likely to be effective and reduce the prevalence of mental illness at a population level. However, researchers and practitioners have also highlighted that the social determinants of mental health are deeply gendered. And we've explored that through webinar 1, as Vanessa just briefly recapped for us. And we certainly saw this highlighted through the COVID-19 pandemic. Given we focused on the top social determinants of mental health in webinar 1 listed here, I wanted to briefly touch on natural environments and public spaces today, particularly given our work for many of us in the active living priority and how we might actually draw co-benefits through also promoting mental health in our work in that space. There's a growing evidence base or growing evidence of the relationship between physical activity and mental health, yet gender inequality prevents women and girls and gender diverse people from being sufficiently active and from participating safely in sports and enjoying the benefits of public space at the same rate as men and boys. The importance of how we design inclusive infrastructure and open space is receiving increasing attention. For your interest, Women's Health East developed a paper on creating inclusive open space, and that was actually written by Vanessa, and that's on our website for anyone who is interested. Women's Health East is also really fortunate to work alongside some of our local government partners who are defined entities under the Gender Equality Act to support and inform the development and redevelopment of infrastructure and open space to be more gender inclusive. Rebecca Clark is here and she's going to share with us her work to promote physical activity and mental health through Step and Connect. I'm looking forward to hearing about that. Another really fabulous example is the Mothers Living Well program, which I don't have time to go into, unfortunately, but I have included the link to that program evaluation report on the resources slide. Thanks, Vanessa. Involving local communities in the development, implementation and evaluation of health promotion programs, as was evidenced through the Mothers Living Well program, enhances community ownership over the program and increases the likelihood of improved health outcomes. Such an approach in mental health promotion is essential to ensure that women's own understandings and experiences and voices around their mental health are reflected in the program, thereby making them culturally appropriate, relevant and safe. And this also, of course, enhances program effectiveness. Meaningful participation also provides the resources and opportunities for women to engage and have a voice over decisions that affect them and their health, which provides the foundations for social inclusion. Thank you, Vanessa. Mental health promotion programs are more likely to be effective when delivered in everyday settings where people grow, study, work, play and live, and when taking a life course approach. Indeed, schools are a common setting for mental health promotion, and there is strong evidence to support their effectiveness. Among adults, we're well aware of workplaces as being a common setting for the delivery of mental health promotion, and these programs have proven to reduce mental illness and support recovery. And parenting programs have demonstrated a reduction in the prevalence of perinatal and postnatal depression among women. And Vanessa's going to present later this morning on her work with mothers of young children through the Kids Coffee and Connection program. For older populations, the most promising interventions are those facilitated through community-based activities and that focus on meaningful social connections. There is, however, an overall lack of interventions designed for older populations. And while young people necessarily remain a priority, further research is required into mental health promotion for older populations and especially for older women. Thank you, Vanessa. Finally, I wanted to highlight our toolbox as health promotion practitioners. Of course, the Ottawa Charter for Health Promotion and our socio-ecological model. And through these models, we're able to be supported to ensure that our mental health promotion programs take an integrated, evidence-based, multimodal approach that addresses various levels of influence. And of course, monitoring and evaluation. Monitoring and evaluation is absolutely key to building the evidence base for gender transformative mental health promotion. Further, given the intersections of gender inequality, violence against women, sexual and reproductive health and mental health, incorporating evaluation indicators to capture mental health outcomes across all health promotion initiatives will enhance the ability to achieve equity and address the drivers of women's poorer mental health outcomes. Thank you, Vanessa. So there are a number of resources here which we've touched on today and which provide a solid foundation for learning more about a gender transformative health promotion approach to mental health promotion. We've included these on the slide. We'll also email them to you, and we really encourage you to take a look. Thank you very much, and I'll hand back to you, Vanessa.
Thanks, Belle. Thank you for that overview. I think it was really good to talk through some of those principles, and hopefully that was useful to people today. We know that it's a lot to pack into just 10 minutes. So again, these resources will be made available to you after the session, and you can also get in touch with us, obviously, if you have any questions about this. Okay. Before I introduce our guest speaker for this morning, I just wanted to remind you, and I can see that there's been a bit of discussion in the chat, but just a reminder, if you have any questions throughout the entire webinar today, please pop them in the chat or direct message Ada, and we'll get to those after the presentation and case study. It is now my great pleasure to welcome our guest speaker for this morning, Monisha Vaid Sandhu from the Multicultural Centre for Women's Health. Monisha has a PhD in public health, a master's in community resource management, and a master's in public policy. She has wide experience and expertise in project management, research, and evaluation. She's passionate about working on women's health and empowerment, and has worked on sexual and reproductive health, maternal health, HIV/AIDS, and sustainable livelihood programs in India, Kenya, and Yemen. At the Multicultural Centre for Women's Health, Monisha has worked on multiple projects in PVOR and is currently working on stillbirth prevention and cultural adaptation of resources for migrant and refugee communities. She is also involved in sector monitoring and evaluation work at the Multicultural Centre for Women's Health. Wow, amazing. Thanks, Monisha. I will just stop sharing my screen. So if you'd like to share yours, that would be great.
Thanks, Vanessa, for an excellent introduction. And also thanks, Belle, for providing an overview to this important work and also the principles involved in it. So today, sorry, before I start, I'll just start sharing. Is it good? Okay, perfect. All right. So, once again, I would first like to thank Women's Health East for providing us this platform to talk about mental health, and also for giving MCWH an opportunity to share our work in this space. So today I'll be discussing the gendered and intersectional factors that impact mental health of migrant and refugee women, and what MCWH has been doing to advance the mental health of migrant and refugee women. Before I begin, I would first like to acknowledge the traditional owners of the land on which we are meeting today. And for me, they are the Wurundjeri people of the Kulin Nation. I pay my respects to the elders past and present, and the Aboriginal elders of other communities who may also be present here today. Now, a brief background of Multicultural Centre for Women's Health. MCWH, it's a national community-based organization that is led by and for women from migrant and refugee communities. We advance the health and well-being of migrant and refugee women through our multilingual information and education, research, training, and advocacy. Now, we know that by definition given by WHO, mental health is a state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to their community. But why do we need to talk about mental health of migrant and refugee women? Well, because they are the lot that fall through the gaps. And that's what has already also been touched upon by both Vanessa and Belle. So, we know the stats and we have the evidence that why we need to work on migrant and refugee women's mental health. Now, the latest stats tells us that 15% of Australian population were born overseas, or to be more specific, out of the total 13 million women in Australia, 4 million were born overseas, which is almost like 30% of women's population, big population. There is ample research and evidence that suggests that migrant and refugee women experience poorer mental health outcomes compared with Australian-born women. But here now, it's very important that care is taken, since migrant and refugee women are not a homogeneous population. And the available evidence also suggests that the prevalence of mental health conditions varies widely across populations. Now, research shows that there are higher rates of mental health conditions among migrant women from non-English speaking background as compared to English speaking background, and also compared to Australian-born women. Some studies have also found that refugees and asylum seekers suffer from higher rates of mental ill health compared with both Australian-born and other migrant population. There are other studies that have confirmed that women arriving through the Women at Risk humanitarian visa are more likely to report mental health conditions compared with women arriving through other humanitarian programs. And similar studies have also found that higher rates of mental distress is present among recently arrived refugees. But again, there is very limited research available for migrant women with disabilities, migrant women who are sex workers, older and younger migrant women and girls, migrant women who identify as LGBTQIA+, migrant women living in remote and rural areas, migrant women experiencing homelessness, unemployment, or any particular financial disadvantage. So there's still a huge gap in evidence. Now, there is also ample research that highlights prevalence and gender variations based on the aspect of mental health being measured. Migrant and refugee women experience greater levels of anxiety disorders or symptoms as compared to migrant and refugee men. There is higher rates of mental distress and PTSD among refugee and migrant women, again compared with men. Perinatal depression or anxiety is the most studied aspect of Australian migrant and refugee women's mental health. And research shows a number of migration-related factors associated with perinatal ill health, including English proficiency, call background, trauma, family violence, to name a few. Now, there are a number of contributing factors that could have a drastic impact on the mental health of migrant and refugee women. First one, settlement stress and trauma. This includes both pre-migration factors, including family separation, violence, war, sexual and gender-based violence, immigration detention, denial of basic living essentials. These factors manifest throughout the migration journey and adds into post-migration settlement stresses, which includes social support and isolation, ongoing family separation, poverty, unstable housing, or homelessness. Then there are employment and material factors. That includes a lack of recognition of skills and qualifications, unemployment, barriers accessing job market, etc. And then, of course, social factors like social integration, loneliness, etc. Now, immigration system and stressors and detention is the second important contributing factor, which includes visa status and immigration detention. Insecure or temporary visa status can have adverse effects upon individuals' mental health. Many post-migration stressors are associated with insecure visa status, such as lack of eligibility for basic social services and medical care, inability to work, long waiting periods for immigration determinations, and fear of deportation or detention. Then comes race and discrimination. Racism and discrimination intersect with other post-migration stressors, impacting significantly on migrant and refugee women's mental health. People who frequently experience racism are almost 5 times more likely than those who do not experience racism to have poor mental health. Then comes the gendered factors and inequality and violence against women. Gender plays a key role, as we all know, in determining the mental health outcomes of refugee and migrant populations. 2 key gendered factors include gender-based violence and gender role stress and changing gender identities. Although gender-based violence, we know, it occurs across all Australian population, gendered forms of violence experienced by migrant and refugee women intersect with other social, political, and economic inequities. They may also struggle with changes in gender roles and expectations during resettlement, which can further play a role in gendered violence, as well as have impacts on both men and women's mental health. It is here now, it is again, it's very important to note that while the issues that I have presented here are presented separately, but they are all interconnected in important and complex ways and should not be considered in isolation from one another. And these inequalities faced by migrant and refugee women intersect with other inequalities, such as those based upon race, religion, disability, sexuality, your geographic location, that all impacts and have impact on the experience of mental health of migrant and refugee women. Now, what are the barriers? The available literature suggests that migrant and refugees face multiple barriers to accessing mental health support, which hinders their ability to access and engage with services. One such barrier exists at the policy level. There is a tendency in Australian policy discourse to discuss migrant and refugee communities as a homogeneous group. Through such homogenizing, policy-making processes fail to meaningfully consider the differing needs of both individuals and communities within the so-called called populations, thereby resulting in lack of cultural and gender responsive policies. Then there are barriers at service at sector level. This includes barriers caused by lack of language proficiency and communication difficulties with health professionals. There also tends to be a lack of reliable and confidential language services, as well as lack of trained bilingual, bicultural practitioners working in the health services. This is related to funding, but also to organizational and sector level policies. Other service side barriers to accessing mental health care include affordability, since there is a gap between Medicare subsidy and cost of service, and very few free services in this sector. Plus, ineligibility for services due to visa status, like those on temporary visa or student visa. Now, time restraints on appointments have also been identified as a service side barrier that can compromise trust building, as health practitioners often lack the ability to address migrant and refugee women's needs in the limited time they have, especially when using interpreters. Then at the community and individual level, there is lack of knowledge and awareness about available services and the referral pathways through which they can access services, majorly because of the complexity of the service system. Social stigma surrounding mental health issues and services within both migrant and refugee communities have also been found to limit the utilization of services. And research exploring migrants and refugees' experiences of stigma has found that in some communities, there is a belief that mental health problems should be kept within the family unit, with some fearing judgment by professionals or that disclosure may put their employment at risk. Migrants and refugees have described feeling otherized and discriminated against by medical professionals based on their religious attire or language proficiency or even accent, and feeling disrespected for holding alternative health beliefs. This again hinders service utilization. There is also lack of availability of relevant and culturally appropriate care options that results in women feeling unheard and even seeking assistance in their country of origin. Be addressed at an early point are left to escalate to a crisis point. Some studies have also found medical models for treatment. A study on perinatal mental health social factors such as loneliness and boredom and socioeconomic stresses.
Oh, Monisha, we're just having a little bit of trouble, I think, with your audio. It's coming in and out. Hopefully it will right itself. But just to let you know, and we'll see how we go.
Is it too bad?
It's not too bad. It's actually been fine. It's maybe keep going and hopefully it'll
Okay,
be
sure. Just yeah, shout out if I'm
just a little bit yeah, just struggling a bit with the audio. Video is fine, but
okay, let me know if it gets worse.
okay.
I'll try to do
We
something.
can still hear you.
Okay. Okay, so now what is MCWH doing to address these barriers? MCWH works towards addressing these barriers for migrant and refugee women through advocacy, training, and capability building by listening to women's voices, delivering education and awareness sessions, and developing in-language resources that can be accessed by migrant and refugee women. MCWH advocates for greater awareness and understanding about migrant and refugee women's mental health issues, and in particular, the gendered intersectional factors that impacts their ability to experience good mental health. MCWH has been actively advocating for the migrant and refugee women's mental health services through submissions and policy briefs. And some of the key submissions and briefs include submission to the Royal Commission into Victoria's mental health services, policy briefs on migrant and refugee women's mental health, perinatal mental health of older migrant women, issue paper on racism and mental health, and a number of presentations in various public hearings. MCWH also works towards building the capacity of the bilingual health education workforce to deliver education about mental health, as well as providing opportunities for their upskilling and professional developments. One of our projects, Let's Talk Mental Health, is providing capability building trainings to around 45 bilingual bicultural health educators to deliver mental health sessions to migrant and refugee women. All our projects are based on the premise of listening to women and engaging them in system reforms. Building Bridges is one such project which enables migrant and refugee women to participate in the mental health reform process through community conversations called Share Circles. The project aims to collect migrant refugee women's experiences of mental health, effectiveness and appropriateness of the mental health system in supporting them, and their priorities and strategies for strengthening prevention and response. We also pioneer in delivering health education sessions to migrant refugee women in their own language, reaching them where they are, including workplaces, playgroups, community organizations, faith settings, etc. These sessions empower them to learn more about their health and also services that they can use. We have developed a number of resources on mental health, including a manual that is used by our health educators to run their sessions, and have a suite of in-language videos on racism and mental health, perinatal mental health, access to mental health locals, etc. And these are the links to some of the videos the first one is about mental health local videos, and this addresses the barriers that migrant refugee communities encounter when accessing mental health and mental services, and introduces the new mental health and wellbeing local services in Victoria. The second video that we have is on perinatal mental health, and here several women from migrant and refugee backgrounds share their experiences of maternity in Australia and what helped them feel more supported as a new parent. And then we have a video on racism and mental health, and this video talks about examples of everyday racism and how you can seek support if you experience racism. And all these videos are available in almost like 20 languages for communities to go through and get to know more about the available services and support systems. Okay, now if we have time, Vanessa, maybe I can just quickly share one of the videos if it is okay.
Yeah, that's fine. Yeah.
Perfect. Is it visible?
I can see the screen. Maybe try the play button again.
Yeah.
See.
As migrant and refugee women, we know that accessing mental health support can sometimes feel difficult or challenging.
It can be hard to know what services are available and how to access them.
You may feel more comfortable talking about your mental health in your first language rather than in English.
We know that out-of-pocket costs can be a worry,
even when you have a Medicare card. If this sounds familiar,
The staff at the Mental Health and Wellbeing Locals are here to help.
this new service supports adults in Victoria to receive mental health treatment and care closer to our homes.
This service is completely free.
It's for anyone aged 26 years and over.
You don't need Medicare.
And you don't need a referral from your GP.
They are being designed to be culturally inclusive and tailored to meet the needs of migrant and refugee communities.
There will be a total of 60 locals available across Victoria.
You can find your nearest local and make an appointment by phone, online, or just walk in.
If you speak a language other than English, call TIS on 131450.
Thank you, Monisha. Thanks for
Thank
that.
you. Yeah, so that was just one example of the resources that have been developed. Yeah, so thank you so much. And
Fantastic.
yeah, and if there are any questions, then we have Joyce as well amongst us. She's the health
Oh,
promotion manager.
wonderful. Wonderful.
So she'll be there to answer all the questions.
Thank you for that wonderful presentation. And yeah, if anyone has questions, just remember to pop them in the chat box. And the slides also will be available to participants after the session also. I would now like to introduce our next case study presenter. We've got Rebecca Clark from Inspiro Health, who will be sharing about her project Step and Connect Women's Social Walking Group. Beck is a health promotion officer at Inspiro, and her focus areas are healthy eating, e-cigarette and tobacco harm, and gender equality. And just to note, Beck is came along today. Really appreciate it, and she unfortunately can't stay around for questions because she has another event to pop off to. But if you do have questions for Beck about the program, please feel free to pop them in the chat still, and we'll make sure we can email them to her, or feel free to contact me also. So Beck, I will pass over to you.
Thanks for the introduction. Hi, everyone. I hope you're all well. Thank you for having me today. I'm just going to share my screen. Can everybody see that? Can you see that?
Yeah, we can. And yeah, you can just pop it onto presenter view. That'll be great.
Yeah, there we go. Got it?
Perfect.
So today I'll be talking about a program called Step and Connect. Megan actually runs this in our health promotion team, but unfortunately she couldn't make it today. So I'm going to be presenting this on her behalf, and I have attended some of the sessions, so I do know a little bit about the program as well. So what is Step and Connect? Step and Connect is an active living project aimed at encouraging increased participation in physical activity and increased social connection for women and girls in the Yarra Ranges. The program was funded by Yarra Ranges Council Community Grant. The program consists of 3 different parts, including a map of all active recreational opportunities in Lilydale, establishing women's social walking groups and a newsletter focused on women's health and interests, and hosting a series of co-designed pop-up events for local teenage girls aged between 12 and 15. For part 1, we have the active recreation map. As you can see on the left-hand side, it's a little bit small, but there are 5 categories, including trails, parks and playgrounds, sports and rec venues, public art, and community points of interest. The aim of this map was to explore the local neighbourhood by foot or bike, visibility of trail connections, visibility of the local points of interest, encourage community connection and pride, and having both a digital and hard copy to make it more equitable and accessible for everyone. For part 2, we have the Women's Social Walk. Why we did this is because the most popular recreation activity for women in the Yarra Ranges is actually walking. Mapping showed a lack of local walking groups in Lilydale, no walks in the areas that catered to the needs of the local women. We had 57 participants in the community consultation, and from that community consultation, we got a lack of opportunity regarding choice of time that suited the women. Women have different health needs, well-being interests, and motivations to exercise, and women encounter different barriers to participate. The actions we had were 2 days and times established based on community consultation, partnership with Lilydale Community House. It ran for 8 weeks from the 4th of May to the 22nd of June. We had 27 women so far participate in the walks, and as a collective, we had 107 walks between all the participants. We had 80 subscribers to the Step and Connect newsletter as well. The key themes from the walk we had were women are motivated by different factors with a high importance of local events, groups that are welcoming and inclusive, options that suit family/work commitments, activity in a relaxed environment, and meeting new people. The next theme we had was mental health benefits of exercise, including physical health benefits, social connection, mental health impact of isolation and loneliness, community-based activity, neighbourhood support, community safety, exercising within nature. And then our last thing we had was the gender lens, which looked at different health needs for women, different motivations and interests for women, including less competitiveness between each other, safety exercising in groups, safety to share experiences and stories. For the outcomes so far, looking at so we had both a daytime and a nighttime walk so that we could cater both of those groups. So for the daytime series, the theme was community connection. Most of the women that attended these sessions actually lived on their own. The women enjoy the walk and spend some time at the community house having a cuppa, a cake and a chat. Majority of the walker profiles are from the morning group. So in the newsletter, we always included a walker profile down the bottom if anyone's seen that, and they're mostly from this group. Walks are around the lake to ensure accessibility for people in wheelchairs and use of mobility devices. So far, we've had 3 women have established another walking group together in their local area. One lady who lives alone stays on for cooking for 1 session. Important, and this is why it's important that we actually have the community house and the program. For the nighttime series, the key theme here was walking in the evening safely in a group setting. We had around 6 to 8 women join the walk every week. These women are either coming directly from work or caregiving. Key mental health needs for these women was to exercise safely as a group, to exercise at a time that is suitable, to form connections with other walkers, to join in on other walks, to enjoy fresh air after being inside at the office all day, to have some me time away from caregiving, and community empowerment with participation. For our last one, we have the Girls Get Active. And why we looked at this is teens often disengage from traditional sport and recreation. Girls often enjoy connection rather than competition, and lack of equitable opportunities. The background of this was we did community consultation again, and we looked at 82 girls who took part. The top 3 barriers that were identified by these 82 girls was time, no local opportunities, feeling embarrassed to exercise in public. For the actions, we had 28 girls express interest in taking part in a focus group later in June. Aim is to host a series of co-design activities, which will be pop-ups, focus on non-competitive and non-structured activities, including dance, beach volleyball, circus, kayaking. Co-design offers this cohort the opportunity to have a seat at the table. When looking at equity, we look at free, local, and during school holidays so that it's more accessible for these girls to participate. When looking at the gender lens, we look at offering activity and social connection opportunities specific to the needs of the girls in this age group. And that is the end of the presentation. So thank you so much for listening to that one.
Thanks, Beck. That was wonderful to hear an overview of that project. And I know that when I first heard about Step and Connect through Megan, I thought, oh, there's, there's some real overlap here with what is really, you know, start as a physical activity project, but it has those links to mental health and to social connection as well. And I think it's good to see a lot of those principles that Belinda talked about as well. So you did co-design approach. You're addressing the gender equity lens, putting like a gender equity lens over the work that you're doing as well, and also looking at the mental health side of that and the implications that has as well. So it's really exciting work, and it was great to hear about the Girls Get Active project as well, and great co-design project there as well. So thank you. And I know you have to jump off now, so thank you very much. And again, any questions for Beck, feel free to shoot them through and we'll get them answered.
Thank you so much for having me.
Thanks, Beck.
Bye.
Bye. Lovely. So we're now on to our next case study. It's my pleasure to introduce my colleague, Sui Sinzar, to present for this morning. Sui will be sharing with us her work on in-language mental health projects. I just want to note she'll also be sharing the work of another of the Women's Health East colleagues, Jane Briaty, who is unfortunately, she has a clash today. She's attending another group she's running, so she isn't presenting today, but she is listening in, I'm pretty sure, and she said she'll be available at the end if anyone has any questions for her. So if you do, pop them in the chat. But Sui is with us. So Sui is a bicultural worker for the Hakachin community at Women's Health East. For the past 2 years, she's been delivering health sessions and running programs in language for Hakachin women, providing them with up-to-date and evidence-based health information so they can make their own informed decision. Before Women's Health East, she decided to give back to her community by working as a multicultural education aide for almost 6 years, where she assisted Hakachin speaking students and families to integrate into mainstream schools. She is also a youth leader at her local church, as well as a community leader at Australia Chin Community, which is a volunteer-based not-for-profit organisation for the Chin community. Also, fun fact, Sui is a freelance makeup artist on the weekend. Thank you, Sui. I'll pass over to you.
Thanks, VC. Yeah, it's a pleasure to be here today. Thanks, Belinda, Rebecca, and Monisha for those amazing presentations. And Monisha actually really greatly captured what I'm about to speak about today. And MCWH does amazing work. So thank you for that on behalf of the community members as well. Let me just share my presentation. Is that good?
Perfect.
Okay. Yeah. Sorry. I might just have to share it like this, because
yeah, that's fine. Whatever works.
Is that all right? Then I have to look at my note on the side. Sorry. Yes, so yep, I'm one of the bicultural workers at Women's Health East, and I'll be presenting on a case study for today, which will be on the projects that the bicultural team have worked on for the last 12 months. And yeah, as VC mentioned, I also want to thank and recognize Jane, my colleague, who collaboratively created this presentation with me. And I extend my acknowledgement to the traditional owners of the country. I am joining from the land of the Wurundjeri Wurrung people of Kulin Nation. Yeah, before we get into the meat of it, I'll briefly introduce the two communities that we have had the opportunity to work with. So first is the Hakachin community. They are an ethnic group from Burma who the majority entered Australia by humanitarian visas, classifying them as refugees. So Hakachin community, they mainly locate in your ranges and Maroondah City Council in Melbourne's eastern metropolitan area. There are around 3,000 Hakachin in the Yarra Ranges. Most of them have little to no English skill or basic education because of the background. And women who participated in our programs are predominantly between the ages of 25 to 55 years old. And the second group that we worked with are that Chinese or Mandarin speaking community. So China is number 3 on Australia's top 10 overseas birth country list. Victoria has the second largest population of Chinese-born migrants in Australia. Mandarin is the number 1 language spoken at home, other than English, of course. And of those who were born in China and speak Mandarin at home, 31% speak English not very well or not at all. So before commencing the projects, we spent a significant time just getting to know the community and better understand the community, which meant that we had to run many focus groups, facilitate countless community engagements, speak with community experts and councils, as well as conducting needs assessments. And through that, we found some common health and social issues for both community groups. And they include, mental health being the big one, especially as it was still in the recovery period from the pandemic, and family violence, parenting and caring for their children. By this, we mean the different style of parenting for different cultures, so like the Western culture and Asian culture, and how that has become an issue as there's generational and cultural gaps between the parents and the kids. Financial stress was a big one as well, which also stems from COVID-19. And last but definitely not least is the scarcity of in-language resources and services that are culturally safe. And so we started our mental health projects. I'm not going to be talking about specific projects, but as the projects combined as the bilingual team. So our project aim, after we identified the issues and the needs of the community, we said that we wanted to support an intersectional gender equal COVID-19 recovery by promoting the social inclusion and mental health and well-being of migrant and refugee women in the Eastern Metropolitan region. And our objective, to achieve that, we had 4 main objectives for the project, and they are to increase awareness and understanding of mental health and well-being, increase understanding of relationships and its impact on mental health, to increase awareness of local mental health related supports, to identify opportunities for social support networks. We worked very hard to achieve this outcome, and we took serious approaches because we knew that it was going to be a big challenge for us as well as the community. So the whole bicultural team worked very closely together to ensure that the content is tailored to populations groups and is made accessible and is culturally safe. We had to challenge the essentialist conception of women's mental illness being inherently biological. We also highlighted how gender inequality negatively influences mental health and well-being, because as we know, gender inequality contributes largely to family violence and financial abuse and so many other things that essentially impact our mental health. As mentioned, we also worked in partnership with local councils, community leaders and organizations within language programs, which there weren't many of them, but MCWH being one. And yeah, so from the project, we had multiple projects running. We each had different, some were run to from 3 weeks to 6 weeks, some are still ongoing till today. But from those, we through the evaluation process, we had so many positive responses from the participants participants, which was amazing, excuse me. Many of the participants indicated that they gained knowledge in mental health and that they became more aware of their individual mental state, which they said is something they haven't really thought about before, which is great. Whether that state is good or not so good, at least they are becoming aware and thinking about it and thinking about what they can do to improve it. In our projects, we also covered referral pathways and available support and services depending on their local area, in which, again, they indicated that they know and are confident to access mental health services. And participants identified mental well-being improvement activities to support self-care plan, and preferred activities are collected. And yeah, at the end, we were able to refer some of the participants to relevant services and according to their needs. We also had some key findings from the project. So we noticed that some of the topics we covered actually conflicted with some cultural beliefs, although we tried to tailor it to the community and try to make it as culturally safe as possible. We also had to tackle the gender equality and how that is contributing to the mental health and well-being of women. And yeah, we found out that some women just found it hard to fathom their husbands doing housework, because culturally that's just was not expected, and men are to provide for the family and women are to just do the household chores and attend to their husband's needs. And yeah, some of the women actually disagree with us, saying, you know, we can share household chores and things like that. And a second thing we found was family violence is a highly stigmatized topic, as was mentioned before as well. We saw that a significantly lower number of participants turn up to these sessions. So our suggestion is that, and for us next time, try to avoid using confronting titles such as family violence, and replacing them with more inviting titles like healthy relationship, or how to make a healthy home, happy household, or something like that. And the next thing we found was low self-care awareness due to economic stress. Because a lot of people after migrating, they had to start from scratch and start building the family again. And they are so focused on their work and just providing for the family and yeah, just making life work, that they often forget to take care of themselves. So the participants were asked if they've, you know, if they've done any self care thing for themselves in the past 3 months. And majority of the participants have not had any self-care activities in the last 3 months, which was very shocking to find, whether that's physical or mental self-care. And the last thing was we found that the key social determinants impact on mental health were parenting stress. As mentioned, there's a lot of pressure from being a parent in a language where you don't know you don't speak the language, and then you can't really cater to especially kids go to school and they are involved in activities. The parents don't know what's going on really, but there's also, like I said, the parenting style difference. What's very normal in their culture is considered maybe unlawful here, and there could be that stress from parenting, and which put a strain on relationships between parents. Could be parent to parent or parent to children as well. And big one is anxiety during the pandemic period as well. So we have some recommendations here, and a lot of these are actually done by MCWH, as mentioned just before. And the first one is on ongoing in language mental health promotion sessions. So like the work that we do here at Women's Health East. It's so important. And just setting up in language mental health support network committee. So Jane is over this slide and these recommendations. So if you have further questions for her, just pop them in the chat and she'll be happy to answer them at the end. And the next one is in language new services or policy introduction sessions. And healthcare services navigation activities based mental health education sessions. So by this we mean, yes, now the women are aware that, okay, maybe they want to get help, but sometimes they don't know how to navigate the system or where they can get help, or if they need an interpreter, how do they do that? So just more activities based and just actually hands-on doing, okay, like if you need an interpreter, try doing this, actually call the service maybe, and then try typing in that TIS number, things like that. So actually like doing it together with them so that they're confident and comfortable. And in language mental health supportive activities, launch in local neighborhood houses, and needs of in language services providers, programs or services introductions, access process, and how does the treatment run. So that's all from me, and thank you so much again for having me today. Thanks, VC.
Thanks, Sui. That was just wonderful to hear about not only the projects, but really those key learnings and the recommendations. I guess it fits really well, especially with what Monisha was speaking about as well. But I think it also highlights those nuances and complexities when you're working with diverse communities, and it's not just a a one-size-fits-all approach when we're looking at health promotion in general and mental health promotion. And when no matter the population group that you're working with, this is the approach that we need to take. And I also just want to acknowledge the other bicultural workers at Women's Health East, Naomi, Esther, and Lindsay. We are very lucky to have our bicultural workers doing work with us. It's really invaluable. So I just wanted to acknowledge them as well. And as I said, keep popping questions in the chat and we'll answer those at the end. Okay. I am just going to share my screen again. All good? All right, I'd like now to share the third case study for this morning. I might just rush through this a little bit because we are actually running a little bit behind. I want to make sure that we have time for questions. But I would like to share about a project that Women's Health East ran in 2022 called Kids, Coffee and Connection, Bringing Mothers Together. It was a social connection program for mothers of preschool age children in the Notting Hill neighbourhood area. The project came about through evidence around the onset of the global COVID-19 pandemic, which compounded existing strains on mental health. Women, particularly new mothers, were found to experience high levels of anxiety, stress, and depression, and felt lonely and disconnected from their community. Our own research through our Parenting in a Pandemic research project, which gathered the lived experiences of women who parented a new baby during COVID-19 and the impact on their mental health. Our findings also supported the evidence around this. Women we spoke with reported feeling lonely, unsupported, and lacking social connection with women that were going through similar experiences, and it had significant impact on their health and well-being, particularly on their mental health. So based on this evidence and taking into consideration the evidence we've spoken about around social connection being key for mental health, Women's Health East received a Monash Council community grant to pilot the Kids, Coffee and Connection project. It provided a space for local mothers in the Notting Hill area to come together to connect and socialise and chat while their children played. It was a time-limited project, a short project. It involved the delivery of regular facilitated get-togethers at the Notting Hill Neighbourhood House with workshop activities delivered based on the needs identified by the women themselves. It aimed to provide social connection opportunities, strengthen connection to and engagement in community life, and to raise awareness of local support services available to women and their children. Women's Health East worked in partnership with the Notting Hill Neighbourhood House to deliver the program. In order to recruit participants, it was promoted widely through multi-organisational social media, newsletters, and also a WhatsApp group through the Neighbourhood House, along with posters in the local area and also a flyer drop around the local area to encourage women to come along. 5 facilitated sessions were delivered fortnightly from March to June in 2022. They were delivered by Women's Health East staff and included workshop activities. And there was an art session, story time, and a gender equity play session. And then 2 more sessions were facilitated by the neighbourhood house staff, as a way of really moving the program on from solely being held by Women's Health East to integrating it into the local community from a sustainability standpoint. So a total of 11 women and 14 children took part in the life of the program. We evaluated it through project officer observations, reflective journaling, and an online survey. We did a one-on-one interview with the neighbourhood house manager, and also it was really important for us to get feedback through those informal conversations that we were having with women that came along to the sessions. Just a couple of, I guess, key things that we learned. So one participant commented it was the first time she'd been out since having her 3rd child, and it was great to be able to come and talk to other mums with similar experiences. We were able to observe mothers coming together and chat over coffee, get to know one another, and also had a snowball effect in terms of participants were inviting their neighbours and their friends and family members to also come along and join the group, which is really, really lovely to see. It was also evident from some of the conversations we had that there was really, I guess, a lack of knowledge and or availability of free or low-cost programs for families of young children in the local area. And by providing, I guess, this program at no cost was an opportunity for participants and their children to engage in these activities. And it really removed, I guess, a bit of the financial barrier for families and to facilitate greater participation for local women. When we spoke to the neighbourhood house manager, she mentioned how the sessions had actually also created an opportunity to engage participants to join other activities that were happening at the neighbourhood house. And she said that even some of the women that came along then enrolled their children in another neighbourhood house program. So I think that was really important to see how those connections were happening, and then they were joining in on other activities that were happening within their local community. I think one of the most significant outcomes of the project was Notting Hill Neighbourhood House's commitment to integrate the Kids Coffee and Connection project into their ongoing neighbourhood house program. So 1 year on from the pilot project, the house still actually has the group running on Wednesday mornings, and they've actually added an additional session on Fridays, which is so wonderful to see. And I guess it really shows that there was a need for something like that in the area. And it's great to see that Notting Hill can sustain the work in that local setting. Although the Kids Coffee and Connection project was a pilot and only allowed for delivery of 5 facilitated sessions, it really did address that need for people in the Notting Hill community. And over the course of the program, the same women and carers returned as well as new participants. A real key strength or success of the project was the partnership between Notting Hill Neighbourhood House and Women's Health East. So it's really working closely with the neighbourhood house who've had those inroads with local community that we wouldn't necessarily have, as well as their commitment to sustaining it past when Women's Health East were funded. We also, on the screen there, you'll see Inchmill Cafe, and they are right next to the neighbourhood house. And again, they were just a really invaluable asset to the project. We got our coffees from there and some snacks and gift bags for the women. And they are just, I guess, like a hub for community members there. So everyone knew Inchmill, and that's where they'd all go to get their coffee, and everyone would chat and then go to the neighbourhood house. So it's such a community vibe that they had, and that really helped facilitate for us a really valuable program. So I guess it really demonstrates that importance of partnering and collaborating with local services when delivering health promotion activities. I think another key strength was being able to be adaptive and flexible with the sessions, because our initial program plan was to make it a walk, but we found, because of the age group of the children and the length of the session and the potential to chat, we actually pivoted it, and we just held the sessions at the house, because that's, after speaking with the women, that's what really they wanted and what they found the most valuable for them and their children. And it was really good to incorporate that level of co-design in the project so that we were able to adapt to meet the needs of the women involved. Some of the key reflections and learnings was that we know that these kind of connection projects do take time to build trust and connections with community, and for participants to build, I guess, connections with each other as well. So especially ones that aim to improve social connection and reduce loneliness and improve mental health, need to be allocated that funding and delivery timelines that can mean that that it's really impactful in the long term. And I think, you know, this goes without saying, because we have actually spoken about this already today, but there's a need to create opportunities for diversity of women to come together, but also the importance of creating opportunities that target specific groups of women who may experience higher levels of marginalisation. And obviously, firstly, understanding the specific needs of different women in the community, including migrant women, and then collaborating and tailoring the design of activities to meet these needs. Yeah, and it was really great to hear from Sui today about the projects that she and the team have been undertaking. I just wanted to briefly just say, in terms of the evaluation methods, we found that some were more effective than others. We had an online survey, but I think we found, just because of the context of women's lives and the time they have children, and it wasn't really perhaps the most appropriate evaluation tool that we could have used. So using that multi-evaluation tool approach, we were able to get some really good data, and especially getting feedback from the neighbourhood house manager and our own observations, and really those informal conversations that we had with women were really important. So I think for us, that was a key learning in terms of evaluation, to really tailor our evaluation tools and framework to the community that we're working with. And I just did want to note that due to the success of project, we applied and were successful for a Yarra Ranges community grant to hold a similar session in the Wurruyallup region with the Wurruyallup Community House. That because needs analysis show there was a high level of disconnection for women from the cohort in that community. So we're in the recruiting phase at the moment, and that program starts in term 3. So please get in touch if you want to know more about that as well. So that actually brings us to the end of the presentations today. So I hope you found them as useful and inspiring as I did. I'll now just unshare my screen, and we will see if we've got some questions. Okay. I can see from the chat, Sui, we have a question for you. From Melissa. So she said, hi Sui, just wondering, if you avoid confronting language when promoting sessions, how do you find the participants that may be triggered or confronted by this topic? How do they respond when presented with the issue during a session, or if they were unaware of the topic?
Thanks, Melissa, for the question. Yeah, our time is very limited, so I'll quickly touch on that. And yeah, it's a discovery that we made recently as well, so we're still trying to work out what's the best way to approach it. But definitely just making a safe space for the women when they come in the session is so important. So just at the start, making sure that they feel like this is a safe space, and you know, everything is obviously confidential, and yeah, just creating that space for them. And I think also it's important to start with the positive side of it. So yeah, actually talking about what makes a healthy home, a healthy relationship, and then slowly transitioning into, okay, if this is healthy relationship, then what is not a healthy relationship. And then also, yeah, just it's important to give them, you know, a warning, like as you're about to switch, just say, all right, we're going to now touch a little bit on family violence and things like that. So if that is a trigger, feel free to take a breather outside, or, you know, do feel anything like that, especially if it's online. They don't have to show their faces if safety is what they're worried about, or use a pseudonym or something like that. So yeah, those are the things that I can think from the top of my head, but it's definitely something that we're still also working on, and trying to, yeah, cater to the best of our ability to the community. Thank you.
Thank you, Sui. I've just had to look through. I can't see any more unless I've missed them in that chat. I know we're right on 11:30, and I want to keep to time. Ada, just checking if you have maybe one last question or anything that's come through direct message to you that you wanted to put forward.
Yes, I just have one question for Monisha, which is, where can we find more information about working in a culturally safe manner in mental health?
We have a number of resources. Offhand, I could think of, though it is not specifically about mental health, but it touches upon culturally safe and responsive services. That's one of our resources on common threads that talks about all the culturally acceptable ways of sharing information to migrant and refugee women. So that gives like overall principles, if I can say, or elements that should be taken care of when approaching migrant and refugee women with any health services. So I believe mental health would also fall under that. If you want, I can share that resource over email. I don't have it handy right now, but
That's
it's
wonderful.
on our website. So if you go on our website as well, and you just type it common threads, I'm sure you will get the link to it. But yeah, I mean, that's one resource that I can think of off my head. And also we have developed a manual on mental health that we are providing training to our, currently we are doing that. We are in the process of doing those trainings with our health educators. So I'm sure that will be available soon on our website as well. So like, you know, you can also access those resources.
Wonderful. Thank you, Monisha. We've actually come to 11:30. So I can see that I can't see any more in the chat, but as I said, if there's any pressing questions, please feel free to email them through to me, and we can make sure that they're answered for you. Just before everyone leaves, I'm quickly going to share my screen again. So you hopefully should all see the QR code that's on your screen. But thank you for everyone who sent through questions. Sorry, we couldn't get to all of them. But as I said, we send them through to me. And we'll distribute the presentation slides and the recording of the session as soon as we can. But before we finish up, I'd like to encourage you to provide your feedback on this session by filling out a brief post-webinar anonymous evaluation by either scanning the QR code that's on your screen, or Ada will be posting a link into the chat. So the information you provide enables us to really continue the work that we do, and it's invaluable to us, and We really appreciate if you could take a few minutes to do the survey for us. That would be most appreciated. I would like to really thank our guest speaker, Monisha, today. Monisha, thank you for coming along and for sharing your knowledge and expertise about migrant and refugee women's mental health. I'd also like to thank Sui for her informative case study presentation on their in-language projects and those key learnings and recommendations, and also acknowledge Beck for sharing with us about the Inspiro Step and Connect project. Thanks also, Belle, for your presentation, and for Ada for being such a help. We've now also come to the end of our webinar, so I'd like to thank all of you for attending today's webinar and for attending our two-part webinar series on women's mental health promotion. We really look forward to working alongside our partners and community as we continue our work in the area of women's mental health. So thank you so much again for attending. Have a great rest of your day. Thank you.
Thank you.
Okay, I think it's just us.